Hey guys, welcome back to MedVidsMadeSimple. In this video, we're going to see about drugs for diabetes mellitus. Now let's begin. Diabetes mellitus is a metabolic disorder in which the blood sugar levels are elevated. The diabetes mellitus can be classified into type 1 and type 2 diabetes. Type 1 diabetes is insulin-dependent diabetes. So basically what happens is, in type 1 diabetes, there will be destruction of the beta cells in pancreas. So the pancreas will not be able to produce insulin which is required by the body. Whereas in type 2 diabetes, what happens is there will be development of resistance to the action of insulin in the target tissues, which means the pancreas will produce certain amount of insulin, but that insulin cannot act on the target receptors present on liver, skeletal muscle and fat, so it cannot exert its action. So that's why it is known as insulin resistant diabetes. Now first we'll talk about treatment of type 1 diabetes. The mainstay of treatment of type 1 diabetes is insulin. Since the insulin is getting depleted in the body in type 1 diabetes due to destruction of the beta cells in pancreas, we need to replace the insulin by giving it externally. So insulin is taken parenterally, mainly through subcutaneous route. Okay, so when insulin is tried to taken orally, it gets degraded by the gastric acid, so it's not preferred to take it orally. To increase its action, it should be taken via subcutaneous route. So insulin is available in many preparations. Based on their duration of action, we can classify them as short acting, intermediate acting, long acting. The short acting insulin is the regular insulin. The intermediate acting insulin is the one which includes lenti-insulin and isophene insulin. The long-acting insulin includes insulin glargine. There is also another group which is known as rapid-acting insulins. This includes insulin lispro and insulin aspart. So these are basically insulin analogues which are made by rDNA technology, also known as recombinant DNA technology. These compounds are highly stable, they have improved pharmacokinetic features, etc. And these are the advantages. So they act immediately as soon as they are administered. Now we'll see one of those insulin analogues. Insulin lispro. Insulin lispro is made by recombinant DNA technology, as I've told you earlier. So how do they do this? The lysine and proline residues present in insulin are reversed in their positions, which means the proline is taken and put in the position of lysine, and the lysine is taken and put in the position of proline. So as the name suggests, lispro, lis stands for lysine and pro stands for proline. This insulin dissociates rapidly following subcutaneous injection as compared to the regular insulin or intermediate acting insulin or long acting insulin. So they dissociate rapidly, which means their action is exerted immediately. So that's why this insulin is taken immediately before or just after the meals. Okay, so that the action will take place immediately after taking food. Better control of glucose levels is achieved using these kind of insulin, and it is also beneficial in the fact that they lower the glycated hemoglobin in the blood, which are known as HbA1c. So commonly the type 1 diabetes is treated with insulin injections. So the most commonly preferred mode of treatment is combining two insulins, which is combining one regular insulin and an intermediate acting insulin. So these two are mixed together and then administered. This is to provide immediate as well as delayed hypoglycemic effects. So what is the reason for combining these two? When you combine regular insulin and intermediate acting insulin, what happens is when you give this into the patient, so this regular insulin will help to lower the blood glucose as soon as the patient eats food. So as you all know, as soon as we eat food, our blood glucose will rise up. So in order to lower that immediately, this regular insulin will be helpful. And in order to sustain the blood glucose levels, even after the action of regular insulin, this intermediate acting insulin is useful. So that's why the regular insulin and intermediate acting insulin are usually mixed and administered in a single injection. Now we'll see about type 2 diabetes. As I've told you earlier, type 2 diabetes is due to insulin resistance. Type 2 diabetes is a major cause of morbidity and mortality across the world. This leads to various complications, which can be classified as macrovascular and microvascular complications, on which we'll be making a video later. So, what happens in type 2 diabetes is basically the body tissues such as liver, muscles, etc., which has the receptors to which insulin binds, will stop responding properly to insulin. Now, this is called as insulin resistance. So, they resist to the action of insulin. So even if insulin is available, it cannot exert its actions. So that's the problem with type 2 diabetes. So before you start treatment for type 2 diabetes patient, there are a few things which you need to advise them. This includes exercise, increased physical activity, diet control, and restricted salt intake too. Now these all are known as lifestyle modifications. Now why did I say restricted salt intake? Because diabetes is most often associated with increased risk of hypertension too. So restricted salt intake can help in that way to control hypertension as well. Now we'll talk about oral hypoglycemic drugs. This is a very important thing which you need to know. So they are active orally, that's why they are given orally. They are not so effective as insulin, because nothing can replace the actual insulin which is present in the body. But still, the advantage is that they need not be injected into the body. The advantage is that they need not be injected into the body as compared to insulin, which need to be injected into the body. The classification of the oral hypoglycemic drugs is done in the following way. There are few drugs which enhance insulin secretion. This includes Sulfonylureas, Meglitinide analogues, GLP-1 agonists, DPP-4 inhibitors. The drugs which help overcome insulin resistance are Biguanides, Thiazolidinediones. There are miscellaneous drugs such as alpha-glucosidase inhibitors, Amylin analogue, D2 agonists, SGLT2 inhibitors. Now we'll talk about each drugs in detail. Now in this picture, we are trying to show the mechanism of action of various oral hypoglycemic drugs which increase the secretion of insulin. Now in the red box on the left corner, you can see that the sulfonylureas and Meglitinide analogues are marked there. So these basically act on potassium ATP channel, so K-ATP channel. Okay, so what do? They prevent the influx of potassium into the cell, okay, into the cells which stores insulin. What is that cell? That cell is beta cell in the islets of Langerhans of pancreas. So when they decrease the intracellular potassium concentration, what will happen? Hyperpolarization. Hyperpolarization will lead to opening of the calcium channels in the cells, and more calcium from outside will start to enter the beta cells. Calcium will also be released from intracellular stores of calcium. So all this calcium will help in release of insulin from the stored granules in the beta cells. Okay, so the granules in the beta cells will adhere to the membrane, and they will release the insulin granules by exocytosis. The other mechanism by which the oral hypoglycemic drugs increase the insulin secretion is shown on the right side. There you can see a receptor which is marked as incretin receptor. So the drugs which act on the incretin receptor to increase insulin secretion are GLP-1 receptor agonists. So what does GLP-1 receptor agonist basically do? The GLP-1 receptor agonists will activate several mechanisms which finally lead to generation of cyclic AMP. Cyclic AMP is also helpful in release of insulin from the beta cell to the exterior. Okay, so this is how they act. Now what happens is, in the body normally there are few substances known as GLP-1, GIP, which are helpful in secretion of insulin. They stimulate secretion of insulin. However, there is one hormone known as DPP-4 which will break down the GLP-1 and GIP into inactive peptides. So what we are doing is we are giving a drug known as DPP-4 inhibitors. This will inhibit the DPP-4, so the GLP-1 and GIP are not degraded. So what's the thing which we need to know is the GLP-1 receptor agonists and DPP-4 inhibitors are given together for their action to be exerted. So better outcome is obtained when they are given together. Now we'll talk about sulfonylureas in a little bit more detail. Sulfonylureas are potassium sensitive ATP channel blockers. They cause hyperpolarization as I've shown in the picture. They open the calcium channels, calcium enters the cell. This facilitates exocytosis of insulin stored in the granules in beta cells to the exterior. Examples of sulfonylureas include tolbutamide, glibenclamide, glimepiride. Tolbutamide is a first generation sulfonylurea, whereas glibenclamide and glimepiride are second generation sulfonylureas. These are very important drugs in recent days. There are a few adverse drug reactions. This includes hypoglycemia, which is lowering of blood glucose. So there are also a few milder side effects such as weight gain, nausea, vomiting, flatulence, diarrhea, headache, etc. Now you gotta know the point that hypersensitivity is an adverse reaction for sulfonylureas. Why is that? It's because of the sulfa group present in sulfonylureas. Okay, so patients who are allergic to it will develop hypersensitivity reactions such as rashes, purpura, etc. So when the person who takes alcohol also takes these drugs, there will be some reactions which are known as disulfiram-like reactions. Disulfiram is basically a drug which is used to treat the persons who are addicted to alcohol. It is used for de-addiction. So when a person who takes disulfiram also takes alcohol, they will develop several reactions which are known as disulfiram aldehyde reactions. So these are known as aldehyde reactions. This includes flushing and all that symptoms. So the same kind of reactions happens when the patient takes alcohol after taking the glimepiride or any other sulfonylurea. Now we'll see about Meglitinide analogues. This includes drugs such as repaglinide and natrelinide. The mechanism of action of these drugs is the same as that of sulfonylureas. These are basically short-acting and they should be taken before meals. Okay, so they can be used to supplement metformin and other long-acting insulins. There are very low side effects associated with these drugs such as mild headache, weight gain, which is also minimal, and this drug is contraindicated in liver disease. Okay, so this should not be given if the patient has any other liver disease. Now we'll see about GLP-1 agonists. GLP-1 stands for glucagon-like peptide 1. So this includes drugs such as exenatide and liraglutide. GLP-1 is normally released in the intestine following glucose intake. So as soon as we take food, what happens is GLP-1 is released from the intestine. So this GLP-1 will induce the pancreas to release insulin. It also inhibits glucagon release. It delays gastric emptying, it suppresses appetite. All these actions sum up to lower the blood glucose levels. Okay, so that's why GLP-1 is very important. So we help to increase its action by giving GLP-1 agonists which act in the same way as GLP-1. GLP-1 agonists are the best drugs to preserve beta cell function. This is a very important thing to know. So if you want to preserve the beta cell function of the pancreas, GLP-1 agonists are the best choice. They also have very low side effects. This is a must-know fact. Now we'll see about DPP-4 inhibitors. DPP-4 stands for dipeptidyl peptidase 4. As I've shown in the picture earlier, this enzyme degrades GLP-1. Okay, so by doing so they indirectly decrease the insulin release. So DPP-4 inhibitors are used to prevent the degradation of GLP-1. That's why we are giving GLP-1 agonists along with DPP-4 inhibitors as combinations to increase the action of each other. Okay, so examples of DPP-4 inhibitors are sitagliptin and vildagliptin. So they do not have any potential to increase the body weight, so the risk of increasing obesity is not here, and dose reduction may be necessary in few cases such as in liver disease and kidney disease. Now we'll see about the most important drug in the treatment of type 2 diabetes mellitus in recent days, which all the type 2 diabetes patients will be taking. It is metformin. Now how does metformin act? Metformin will basically cause activation of AMP dependent protein kinase. So by doing so, they will have many actions. So they basically suppress hepatic gluconeogenesis, they increase glucose uptake in skeletal muscle cell fat, they also retard intestinal absorption of glucose. So if you see all these functions, it all sums up to give low blood glucose levels. Okay, so the blood glucose levels are lowered significantly, but you got to know the fact that metformin will act only if there is at least some amount of insulin in the blood. Okay, so there are very few mild side effects associated with metformin. This includes abdominal pain, nausea, diarrhea, etc. And it is contraindicated in cases such as hypertension, heart failure, severe liver, kidney, or any respiratory diseases. So if the patient has kidney disease and when they take metformin, the risk of lactic acidosis is very high. Now we'll see about the next group, thiazolidinediones. Now these are basically agonists for nuclear peroxisome proliferator activated receptor gamma, PPAR gamma. So if you can't remember the whole thing, you can remember PPAR gamma. So these are agonists for PPAR gamma. The drug which is present in this group is pioglitazone. They act mainly in the fat cells, and they also have actions on muscles and some other cells in the body. So they act on fat cells, muscles, and they increase the expression of transporters, mainly GLUT4. Okay, they increase the expression of GLUT4 receptor transporters. So by doing so, the glucose uptake into muscle and fat is improved. This will lower the blood glucose level. They also lower the triglyceride level and they raise HDL. Triglyceride level has to be lowered in the blood, so this is a beneficial effect. And they raise HDL. HDL is actually good cholesterol, so that is also a beneficial effect. But the things to keep in mind while you prescribe thiazolidinediones is that they can precipitate congestive heart failure if the patient already has any significant heart disease, and in few cases hepatic dysfunction may occur. And if the patient is taking OCPs, oral contraceptive pills, the failure of those drugs can occur. So because these will basically increase the degradation of the oral contraceptive pills by activating few enzymes in liver. So you need to keep these things in mind before you prescribe thiazolidinediones. Now we'll see about alpha-glucosidase inhibitors. These includes acarbose, meglitol, and voglibose. They inhibit alpha-glucosidase enzyme, which is present in breast border of intestinal mucosa. So this alpha-glucosidase enzyme basically helps in digestion of carbohydrates. So when digestion of carbohydrates takes place, glucose will be absorbed into the blood. So when they prevent the digestion of carbohydrates, glucose cannot be absorbed into the blood. So this prevents rise in blood glucose. But the thing is, there will be undigested carbohydrates which will stay in the large intestine for a long time. And what happens due to the enormous amount of microflora present in the large intestine. What happens is, due to fermentation of the undigested carbohydrates, increased gas production, that is increased flatulence and abdominal discomfort occur. So it is not well tolerated by the patients. Now we will see about amylin analog. Amylin analogues basically acts in brain to reduce glucagon secretion from alpha cells in pancreas. They delay gastric emptying, they retard the glucose absorption, and they cause satiety. All these actions are basically to lower the blood glucose levels, as any other oral hypoglycemic drug does. So the example of amylin analog is Meglitinide. So this drug can be used as an adjuvant to other hypoglycemic drugs. Now, dopamine D2 receptor agonist. So the drug which is included in this group is bromocriptine. So it is given once daily every morning. So that's sufficient. And the mechanism of action is that they act on hypothalamic dopaminergic control of circadian rhythm, of hormone release. They control various hormone release, such as ACTH and few other hormones which are released from hypothalamus. By doing so, they indirectly helps to overcome insulin resistance. So they can be used as adjuvant to diet plus exercise plus metformin. Now we'll see about sodium GLUT2 inhibitor, or SGLT2 inhibitor. The drug in this group is dapagliflozin. So normally the glucose which is filtered in urine is reabsorbed in proximal convoluted tubules by a transporter known as SGLT2, which is sodium glucose cotransporter 2. So if sodium glucose cotransporter 2 is inhibited by this drug, the glucose cannot be reabsorbed in the proximal convoluted tubules, so they are excreted in the urine, which lowers blood glucose, and it also helps in losing weight. Once daily dosing of sodium glucose transporter 2 inhibitor is enough. So the side effects associated with them are increased incidence of urinary tract infections, genital tract infections, and increased frequency of urination. Now, why does this occur? Since most of the glucose is excreted in urine, the glucose in the urinary tract increases, and this serves as a culture media for many bacteria. So that's why urinary tract infections is increased. Now, how do you start treatment for type 2 diabetes patients? The first drug which you need to start for type 2 diabetes patient is metformin at the time of diagnosis. Okay? So along with that, you'll advise several lifestyle modifications such as exercise, diet control, and a non-sedentary lifestyle. The second drug, if needed, is you can add sulfonylureas. Okay, so when you start giving metformin and you advise lifestyle modification, but if still the blood glucose levels are not controlled, you can add a sulfonylurea. So even after adding sulfonylurea, if the blood glucose is not under control, you can add pioglitazone to that, and you can adjust your treatment accordingly. If the patient is resistant to all the treatment, finally the treatment choice is insulin. In our upcoming videos, we'll be talking about diabetic ketoacidosis, hyperosmolar coma, and there are much more content coming up for you. So subscribe and stay tuned to get notified about our upcoming videos. We would like to thank Mr. M. Behruz. He is the first person to support us by donating through our Patreon page. He has donated $80 and motivated us to continue our work. Thank you so much, Mr. Behruz. Donate us a small amount every month through patreon.com/MedVidsMadeSimple and check out all the rewards you get by donating us various amounts in Patreon. Your support will motivate us to make more videos and also to improve the quality of the content in our upcoming videos. Donate $75 or more through patreon.com/MedVidsMadeSimple, and by doing so you'll get access to ask your doubts through Discord app. You can download our lecture slides, get your names on our videos as major contributors for 9 months, Hurry up, this feature is available for the first 10 people only. Thanks for watching. Please subscribe to our YouTube channel MedVidsMadeSimple. Share this video to your friends and please tell them to subscribe to our channel. Thank you.